It is my pleasure and honor to be here to meet with you all and speak about HPV and HPV-associated cancers, a topic that is very close to my scientific heart. So, just brief objective or background of my talk. What I would be doing today is going over contemporary epidemiology of cancers caused by HPV and try to explain how understanding inequity in the epidemiology and differences in epidemiological patterns could help us guide uh, in terms of identifying opportunities for cancer prevention and control. I come from decision science background, and over the last few years in some of our scientific work, we have integrated a lot of cancer epidemiology in our decision science. So I'll talk from the perspectives of both decision science and cancer epidemiology, in that how we're learning from both the domains and how we're integrating methods from cancer epidemiology in some of our decision science work to help in decision making, identify uncertainties in decision making pertaining to cancers caused by HPV. I largely focus about cervical, anal, and oropharyngeal cancers that we are mostly emphasized on at this point. So, human papillomavirus and 6 cancers that it causes. We know that HPV is a sexually transmitted infection. There are more than 200 strains of HPV. But the major culprits that are responsible for causing 6 cancers are HPV type 16 and type 18. We live in this in the era where collective incidence and mortality of cancers is decreasing nationwide, but that's not truly the case for cancers caused by HPV. Like I said, there are 6 cancers that HPV causes, and 5 of those are rising very rapidly: vaginal cancer, vulvar cancer, oropharyngeal cancer, anal cancer, and penile cancer. We recently also showed that cervical cancer, for the first time in several decades, has stabilized, plateaued. So we are seeing no decline in cervical cancer incidence that we are observing over the last several decades. In this plot, in panel A, as you can see, oropharynx cancer, for instance, HPV-associated oropharyngeal cancer, has increased very rapidly, and it has crossed cervical cancer to become the most common HPV-associated cancer. It's been 10 years now since this pattern occurred. Why HPV-associated cancers are important? Because we also know that persons who have index HPV-associated cancers, they are at risk of developing second primary HPV-associated malignancies. For example, cervical, vaginal, vulvar cancer survivors are at risk of developing anal cancer. So in terms of prevention of HPV-associated malignancies, it's important that we prevent index cancers so that there's an opportunity to prevent future second primary cancers. Cancers that are caused by HPV, they typically follow this natural history pattern where individuals in the absence of infection, individuals who don't have HPV infection, in younger ages, they will acquire HPV, cancer-causing HPV infection. HPV infection, if persist, certain strains, if persist, a small proportion of individuals will progress and develop precancerous lesion, which is we call it high-grade squamous cell intraepithelial lesion in the context of anal cancer or precancer. And persons who have precancer, persistence of precancer, will be at risk of developing anal cancer or cervical cancer, for instance. So understanding natural history of HPV and HPV infection is truly important, because if you understand this carcinogenic pathway where individuals in the absence of HPV will acquire HPV, and then there's prevention. So it really helps us to think in terms of where to intervene and where to prevent these cancers. So for instance, primary prevention, HPV vaccination. If we can prevent acquisition of HPV infection, we can cut down the entire carcinogenic pathway. Individuals will not develop precancer and will not progress to cancer. So it's thought of as a measure that's important for our adolescents. So vaccinating young adult adolescents will prevent HPV-associated cancers over their lifetime. Individuals who have HPV infection and the infection has persisted and has translated into precancerous lesion, we have opportunity to detect precancerous lesions and treat them. So at least for cervical and anal cancer, we have the capability to detect precancerous lesions, screen for cervical and anal precancer and treat them. As a result, there is a likelihood of preventing cancers, invasive cancers. So like I said, there are opportunities for primary prevention, opportunities for secondary prevention, and natural history framework guides us towards that pathway. So I'll talk about our work largely focused on cervical cancer, what we have learned in recent years and what we are working on. So we know that over the last 50, 60 years, cervical cancer incidence has dropped substantially in the US from nearly 30 per 100,000 to nearly 7 or 8 per 100,000. So this is the data, historic data from 1970s to 2016 from SEER, where there was a rapid decline in cervical cancer. And in terms of guidelines for cervical cancer, prevention for cervical cancer, it has evolved substantially from 1930s to now. For instance, in 1930s, cervical cancer mortality rate was very high in the US. Screening was introduced in 1960s and 70s. And as a result of that, we started to see a very rapid decline in cervical cancer mortality in 1990s when mortality declined to nearly 7 per 100,000. Screening guidelines have also evolved over the last several years. From annual cytology to now, we have evidence-based screening recommendations where we have tests that are highly sensitive, specific, high-risk HPV testing. And introduction of new tests has truly allowed us to enhance that screening interval from annual to every 5 years now. And tests are much better in terms of detecting precancerous lesion. So cervical cancer guidelines have evolved and cervical cancer mortality declined in the US. But what we observed a few years ago in our publication when we quantified cervical cancer incidence trends, and that that served as a motivation for some of our recent work focused on cervical cancer, is that in the US from early 2010s, cervical cancer incidence, the decline that we were observing has stopped, and there was a plateauing of incidence from early 2010s. So we and my team were very curious to understand what might have triggered the plateauing of the incidence, what may have and to quantify or to understand the change in pattern. What we started doing is we started analyzing several national databases and trying to understand whether there are different age or risk groups that may be seeing differences in terms of cervical cancer incidence patterns. Our second observation that was a strong motivator for some of our recent work was that we know that cervical cancer screening rates in the US are decreasing substantially. So particularly among women who are in their early 20s, 20 to 29-year-old, there was a rapid decline in cervical cancer incidence over the last 15, 20 years. So, two observations. Nationally, overall cervical cancer incidence has plateaued, and cervical cancer screening rates have declined among young women, particularly. So, the question that we wanted to ask was that given that there is a decline in cervical cancer screening among youngest age group, 21 to 29, whether there is differences in age-specific cervical cancer incidence patterns. So in a recent publication, we quantified hysterectomy-corrected cervical cancer incidence according to age. And what's important here to note is that when we look at incidence and stratify them, incidence patterns according to age, women who are in their early 30s, 30 to 34-year-old, after a rapid decline from 2001 to 2012, from nearly 13 to 10 per 100,000, cervical cancer incidence, the decline has reversed, and we are now seeing a very rapid increase among the recent birth cohort. So from 2012 to 2019, the incidence has increased at nearly 2.5% per year. Among women who are in their mid-30s to mid-50s, if we look at incidence patterns, so these are the age groups that have experienced stabilization of cervical cancer incidence. So the way we interpret these findings is annual percentage change in this case is nearly close to zero. That means there's no change in cervical cancer incidence patterns among these age groups. So two important findings here. Among women who are in their early 30s, cervical cancer incidence is rising, and those who are in their mid-30s to mid-50s, incidence may have plateaued. We further stratified incidence trends among women who are in their early 30s according to race, ethnicity, stage at diagnosis, and histology. So these findings, why they're important is that the race or ethnic groups that are seeing rise in cervical cancer incidence, they're Hispanic and non-Hispanic white. So two race ethnic groups, Hispanic women and non-Hispanic white women, are seeing 3% per year increase in cervical cancer incidence. The increase is also concerning because we're observing rise in incidence for both localized and regional cervical cancer. and that for squamous cell histology. So if squamous cell carcinoma is rising, that's an indication of disruption along screening and treatment pathways, perhaps. So that led to our hypothesis that there may be something on cervical cancer screening and treatment continuum that may have triggered the rise in cervical cancer incidence. So the rise, if it is if it is driven by screening, then we are likely to see more cervical cancer cases that are early stage, perhaps, but there may not be increase in advanced stage cervical cancer. And if the incidence is true, then we may see increase in advanced stage cervical cancer and perhaps rise in incidence-based mortality. So I'll get to those findings, and I'm going ahead of the slides. So the next question that we wanted to ask is that nationally cervical cancer incidence among some groups may be rising, but are there disparities driven by socioeconomic status? So this study last year, we estimated cervical cancer incidence patterns according to county level household income. What's important here to note is that women who live in lowest income counties or lowest income neighborhoods, they're the ones who are seeing the reversal in cervical cancer incidence. So red line is representative of low income women, and the green color is representative of high income. Now, there are two findings that are important here. Is that reversal in cervical cancer incidence, although in this study we observed 1.6% per year increase, the increase was not statistically significant, but also disparities in terms of the gap in the absolute incidence for 2018 that we're observing between triangle and circle. There's substantial gap in among women who live in high-resourced neighborhoods. The absolute incidence is close to 7, and those who live in low-income neighborhood, it's over 10 per 100,000. I also work very closely with colleagues at the University of Puerto Rico Cancer Center. And in Puerto Rico, we have been studying cervical cancer incidence patterns for several years now. And in Puerto Rico, it's very similar to, it's a similar setting to Appalachian Kentucky, where a high proportion of women live in persistent poverty. There are substantial disparities in cancer prevention, and the disparities have magnified over the last few years substantially. So it's in Kentucky, as opposed to the national pattern, cervical cancer incidence has been increasing very rapidly over the several years. Using claims data from low-resource women in Kentucky, we also quantified cervical cancer screening utilization over calendar year. So this is the data from Kentucky Medicaid, where we quantified cervical cancer screening patterns, so cervical cancer screening rates each month. And what we observe here is that every time a disaster event struck Puerto Rico, cervical cancer screening rates dropped substantially. So post Hurricane Irma, for instance, and Maria, cervical cancer screening rates were higher and they dropped and have never ever recovered after that. So each time we have a disaster event, screening is further getting disrupted. There's further decline, and post COVID-19 lockdown, the screening rates, what we are observing in recent time, is very low. So what we are doing in Puerto Rico, so I shared some of our descriptive work in terms of our recent work and recent studies in Puerto Rico. I'm very excited about this new project that just was very recently funded, last month in fact, where we're evaluating the effectiveness, cost effectiveness, and budget impact of interventions to improve cervical cancer screening delivery in Puerto Rico. It's a large clinical trial of nearly 1,500 women. I'm co-leading this work with my dear colleague Ana Patricia Ortiz, where we are comparing 4 strategies: patient reminder, patient navigator, self-sampling, and self-sampling plus patient navigation. So multi-component interventions to improve cervical cancer screening uptake and follow-up care. Our objectives are to measure effectiveness, cost effectiveness, budget impact, and downstream impact on cancer risk and mortality. So I talked about cervical cancer, some of our work in cervical cancer, and mostly shared concerning or disturbing patterns. Then you might ask me, Ashish, is there any good news now in terms of cervical cancer prevention? So there is HPV vaccination. It's been almost 2 decades now, since close to 2 decades when the HPV vaccination was implemented in the US. And we have started to see early benefits of HPV vaccination, particularly among youngest birth cohort. So these are our 2 publications from last year, where we estimated HPV 16-18 infection prevalence among women in the pre-vaccination era and in the recent time, 2015, 2016. So as you can see, cervical HPV 16-18 infection prevalence pre-HPV vaccination era was much higher, 15%. But in recent time, among those who are both vaccinated as a result of direct benefits and unvaccinated as a result of herd immunity, HPV 16-18 infection prevalence has dropped substantially. In the same study, we also showed that women who were born in 1990s as opposed to women who were born in 1980s have much lower HPV 16-18 infection prevalence. So that's a positive. That's a good news because as these birth cohorts will translate or age into older age groups, they are more immune to developing HPV-associated malignancies, particularly cervical cancer. Now, we are seeing some of that translation of infection prevention into cancer prevention among the youngest birth cohort. So if we look at women who are less than 24-year-old, in recent times, cervical cancer incidence is decreasing very substantially. So from 2012 to 2019, among youngest birth cohort, we observed nearly 65% decline or nearly 12% per year decline in cervical cancer incidence. Among 25 to 29-year-old age group too, we are seeing some decline, 7.5% per year decline, although it was not statistically significant. So as we can see, there is a greater potential for cervical cancer and cervical HPV prevention as a result of HPV vaccination. And it's likely that the benefits that we are seeing among youngest age groups, women who are in their 20s, will translate to women who are in their 30s and 40s in subsequent decades. So I talked a lot about our work largely focused on cervical cancer. Now I'll transition towards anal cancer, another HPV-associated malignancy that has been increasing very rapidly in the US. And the focus on our work largely on anal cancer epidemiology and prevention from the prevention perspective. So like I said, anal cancer, it's one of the 6 HPV-associated malignancies rising very rapidly among women, particularly those who are in their 50s and 60s. In the United States. So what do we know about anal cancer worldwide? Worldwide, globally, in 2020, nearly 51,000 anal cancer cases were diagnosed. Of those, nearly 30,500 were HPV attributable. And majority of anal cancer burden occurs among women. 65% of anal cancer cases worldwide occurred among women, 35% in men, and mostly in high HDI countries, Human Development Index countries, is where anal cancer burden lies. In the United States, anal cancer, particularly HPV-associated anal cancer, squamous cell carcinoma of the anus, has increased rapidly, nearly 2% per year among men, and nearly 3.1% per year among women. The incidence trends for the histologies, adenocarcinoma, melanoma, or other, it's either decreasing or stable. So which age groups are disproportionately affected by anal cancer? Women who are in their 50s and 60s are seeing the market increase, most rapid increase over 5% per year. And also men who are in their 50s and 60s are seeing rapid increases in anal cancer incidence. What's important here to note is that when we think of anal cancer and compare it with other HPV-associated cancer, so in the spectrum of other HPV-associated malignancies, when we compare anal cancer incidence with cervical cancer, particularly among non-Hispanic white women who are seeing marked increases. Among those who are in their 60s and 70s, anal cancer has now surpassed cervical cancer to become the most common HPV-associated malignancy. And the gap between anal and cervical cancer is decreasing among white women who are in their 50s. We also know anal cancer is associated with aging, and in a recent work, we quantified anal cancer incidence and mortality patterns, where we observed that among youngest age group, less than 50-year-old men, anal cancer incidence is decreasing, but both anal cancer incidence and burden is rising very rapidly among men and women who are 50 years old or older. Also, anal cancer mortality, there is a mortality rate increased nearly twofold in this age group, and mortality burden has also increased substantially. So I talked about anal cancer incidence and changes in anal cancer trends and patterns that we're observing in our study work with IR, where we quantified global anal cancer incidence patterns and burden. What we observed is that given the high risk of anal cancer among persons living with HIV, if we quantify persons living with HIV who have anal cancer, HIV-infected anal cancer cases, worldwide, nearly 1/5 of all anal cancer cases among men occurred among persons living with HIV, whereas contribution of HIV to anal cancer burden was lower, less than 3% per year. The contribution of HIV to anal cancer burden varies substantially by world regions. It's highest in North America, for instance. 1/3 of all anal cancer cases among men occur among persons living with HIV. And among women, Africa is a region that particularly stands out because 1/5 of all anal cancer cases in Africa occurred among women and 30% occurred among men. So can we prevent anal cancer? We have a very strong sense of anal cancer natural history now. We know that it follows a very similar carcinogenic pattern and natural history, similar to cervical cancer, where persons who have persistent HPV will be at risk of developing precancerous lesion, and persons with persistent precancerous lesion may progress to cancer. So this carcinogenic pathway is essentially guiding our thinking in terms of how we can prevent anal cancer and optimize anal cancer prevention. So similar to cervical cancer screening, anal cancer is preventable using screening, although we don't have evidence-based national guidelines yet. And we are in the process. Very soon, CDC will be launching the National Anal Cancer Screening Guidelines, and EANS will be releasing the anal cancer screening recommendations, largely driven by the findings from the anchor study that I believe Dr. Joel Palevsky, who visited you a few years ago, shared and recently published. So similar to cervical cancer, screening is possible. We use a cytology-based approach where individuals with cytologic abnormality or high-risk HPV, they receive diagnostic high-resolution anoscopy test. The objective of HRA, high-resolution anoscopy, is to detect precancerous lesion. And if individuals have precancerous lesion, they receive treatment with the objective that treatment will prevent progression to invasive cancer. In terms of defining anal cancer risk and who we should be screening for anal cancer, this is a very nice meta-analysis that my colleague Gary Clifford from IARC led a few years ago, where he quantified anal cancer incidence among various risk groups. And as we can see, it's truly possible to quantify incidence among various risk groups and separate it. For example, men who have sex with men living with HIV. With increasing age, anal cancer incidence increases. So MSM with HIV, they have highest anal cancer risk. And those who are less than 35-year-old, incidence is less than 25 per 100,000. With increasing age, it exceeds, and those who are 45 years or older, incidence exceeds 100 or greater per 100,000. The other risk groups that stand out in terms of anal cancer risk and that needs to be prioritized in terms of anal cancer prevention is non-MSM heterosexual men living with HIV. They also have elevated anal cancer risk. Women living with HIV have elevated anal cancer risk. With increasing age, again, incidence increases. Other risk groups that are important target for anal cancer prevention now are cervical, vaginal, vulvar, pre-cancer or cancer survivors, particularly women who have had history of vulvar cancer. Anal cancer incidence among this risk group is nearly 50 per 100,000. And other non-HIV immunocompromised individuals, solid organ transplant recipients, persons with lupus, ulcerative colitis, Crohn's disease. Now, in terms of guiding anal cancer prevention and defining risk, the principle that the field is considering is equal risk, equal management, or equal risk, equal prevention. And largely guided by this principle, they have identified different risk scales that qualify individuals for anal cancer screening. A risk scale or a threshold that the International Anal Neoplasia Society has considered is incidence of over 10-fold compared to the general population. So within this risk scales, person who have anal cancer incidence of over 10-fold compared to the general population are considered for anal cancer screening recommendations. France, for instance, French Society of Coloproctologists, they consider 50 over 100,000 as a risk group. I know a few organizations are considering absolute incidence threshold of 25 per 100,000. So this absolute incidence scale truly provides us a guidance in terms of who we should be screening and whether absolute risk could be considered in terms of guiding screening strategies. One risk group that particularly stands out in this on this scale, which was center of substantial debate in our field, was MSM in the absence of HIV. What's the anal cancer incidence in this risk group, which is a very large group in the United States? Can we further age stratify anal cancer incidence in the absence of HIV among MSM? So we recently performed a data-driven epidemiological analysis where we quantified anal cancer incidence among MSM in the absence of HIV and updated the risk scale. Now, what we can see here is that among MSM, in the absence of HIV, it follows a similar age-specific pattern in that incidence increases with increasing age, and MSM without HIV, those who are 45 years old or older, they have absolute incidence of over 10-fold compared to the general population. So based on this principle, if we are to develop age-based anal cancer screening recommendations, MSM without HIV who are 45 years or older, they qualify for anal cancer screening. So from defining anal cancer screening and risk group that should be considered for anal cancer screening, how can we inform evidence-based anal cancer screening recommendations? So the framework that we are following in terms of identifying and answering key questions for anal cancer prevention is the one that is suggested by the US Preventive Services Task Force, that analytic framework. So what US Preventive Services Task Force does is that they have 8 key questions, and it's important to answer those key questions in order to consider screening for certain cancer. So the key questions that USPSTF framework asks is there direct evidence that screening reduces morbidity and or mortality? What is the prevalence of disease in the target group? Can a high-risk group be reliably identified? Can the screening test accurately detect the target condition? Does treatment reduce the incidence of the intermediate outcome? Does treatment improve health outcomes for people diagnosed clinically? Is the intermediate outcome reliably associated with reduced morbidity and or mortality? Does screening result in adverse events? What are the harms and benefits associated with treatment? So one of the most important barriers that was precluding us so far in terms of developing anal cancer screening recommendations was this very big key question in the field, that can treatment for anal precancer prevent occurrence of anal cancer? Whether treatment versus when we think of comparison of treatment versus active monitoring, whether treatment is efficacious or effective compared to observation or natural history, and what's the extent to which treatment reduces anal cancer risk. So to answer this important question, Dr. Joel Palevsky at UCSF, he led very important, the National Anchor Study, which was concluded last year, and the publication also came out in last year, where they compared active monitoring versus treatment among over 5,000 persons living with HIV with anal precancerous lesion. So what they observed in the Anchor study, what Palevsky and colleague observed was that when we compare active monitoring against treatment, treatment substantially reduces anal cancer risk. There was 57% reduction in anal cancer risk over the duration of 4 years. And it also answered several key questions in terms of what are the harms associated with treatment, in terms of its quantified side effect. And it was evident that the side effects were not really invasive. So treatment is efficacious, it reduces anal cancer risk. And given this knowledge, several professional organizations now are steering towards developing anal cancer screening recommendations. So it is serving as a foundational knowledge for the for the field. So the questions that we wanted to ask, given the findings from the Anchor, was question 4B: how do efficacy and effectiveness of treatment compare in the community settings? Is the intermediate outcome reliably associated with reduced morbidity and or mortality? So in the Anchor trial, the outcome of interest was cancer incidence, whether reduction in cancer incidence would translate into reduction in cancer mortality. And if we are to conduct Anchor trial at a community setting, where we might see differences in terms of screening and treatment compliance, how the outcomes might look like. Now, translating from evidence-based anal cancer screening recommendations to the challenges that we're facing. Currently, the major challenge in terms of anal cancer prevention is high-resolution anoscopy. It's a resource that it's a scarce resource. it is a limited resource in the US, in that only 181 HRA clinics are there in the US. And most of these clinics are largely concentrated in California, New York, and Florida, in coastal US states. So if we are to develop evidence-based anal cancer screening recommendations, it's also important to generate a robust screening infrastructure, in that we don't have individuals who fall back on receiving timely anal cancer screening and follow-up care. The states where I'm from, South Carolina, we only have 2 HRA providers, and there are several states in the US where we don't have any HRA providers. So if we are to develop anal cancer screening recommendations, it would be important to also have emphasis on screening and treatment infrastructure development. So from my work on anal cancer, now I'll talk a little bit more about our work on oropharyngeal cancer. So what we are studying in terms of oropharynx cancer prevention. And this is largely work focused on mathematical modeling, disease simulation modeling. So oropharynx cancer incidence among men is rising very rapidly, over 3% per year increase. It has surpassed cervical cancer to become the most common HPV-associated malignancy. And we also know that oropharynx cancer incidence is largely increasing among men who are in their 50s and 60s. And there's some evidence that it may be increasing among women who are in their 50s. So different than anal cancer prevention. I think I have, so I'll try to move my slides a little quicker. Different than anal cancer prevention, we do not have the ability to detect precancerous lesions. So prevention for oropharynx cancer largely relies on detection, prevention of HPV infection. So primary prevention through HPV vaccination. We also know that HPV vaccination is efficacious in terms of preventing oral HPV infection. This is a work where we estimated oral HPV infection using enhanced data and observed substantial reduction in HPV infection prevalence among those who were vaccinated compared to those who were not. But the challenge that we are seeing in the US is that HPV vaccination coverage is lower. So healthy people 2030 has come up with goal of achieving 80% HPV vaccination coverage, but coverage in 2021 is 60% overall, and slightly lower among boys compared to girls. There's also a substantial barrier to HPV vaccination prevention, in that we showed that 60% of parents of unvaccinated adolescents lack intent to initiate HPV vaccination. And the hesitancy, HPV vaccine hesitancy, is rising in the US. There was substantial, significant increase in the rise in safety concerns as a barrier to HPV vaccination among parents across all US states. So given that the coverage is suboptimal and it's important to achieve HPV vaccination coverage, the question that we wanted to ask was that if we are able to achieve 80% coverage, how that would translate into oropharynx cancer prevention. So similar to anal cancer, we developed an oropharynx cancer natural history model that simulated the oral HPV and oropharyngeal cancer natural history among boys and girls in the US. So mathematical model had an representation of HPV natural history in that persons with persistent HPV infection, particularly type 16, were at risk of developing oropharynx cancer over their lifetime. The first step in model synthesis was model validation, where we compared model-generated intermediate and final outcomes in terms of oral HPV infection prevalence and oropharyngeal cancer incidence compared to various US-based databases. And as we can see, oral HPV infection prevalence patterns according to age were fairly similar, so as the oropharyngeal cancer incidence, both model-generated findings and observed oropharyngeal incidence and burden patterns. We then projected oropharyngeal cancer incidence. So after calibration and validation, we projected oropharyngeal cancer incidence patterns over the 21st century, over the next 80 years. And what we observe here is that it's likely that the oropharyngeal cancer incidence will continue to rise in the US, particularly among men who are in their 50s, 60s, and 70s. The earliest decline that we'll see will be among youngest age group. So this is under status quo HPV vaccination scenario, in that oropharynx cancer burden will continue to rise. And if we look at age distribution of oropharyngeal cancer burden, in the future years, majority of oropharyngeal cancer burden will occur among men who are in their 60s and 70s. So there will be age distribution, a shift in oropharyngeal cancer burden in the future year. What we also observed is that currently HPV vaccination coverage is suboptimal, but and under status quo or existing HPV vaccination coverage, if we are to make oropharynx cancer a rare disease, in the US we use incidence threshold of 4 per 100,000. It will take nearly the end of this century to make oropharyngeal cancer a rare disease if HPV vaccination coverage is not improved. But improvement in HPV vaccination coverage from nearly 60 to 80% would lead to rapid reduction in oropharyngeal cancer incidence in future years. So we can make oropharyngeal cancer a rare disease nearly 30 years prior in 2070s. As a result of HPV vaccination, there is a great potential to prevent nearly 1 million oropharyngeal cancer cases over the 21st century. And what we observed is that compared to status quo, we can prevent nearly 150,000 additional oropharyngeal cancer cases over the next century. So with that, thank you so much for inviting me.